All right. Welcome to Ultra Rounds, everybody. Thanks for joining us once again. Today, I have the pleasure of introducing Dr. Jeremy Vandelinde and Dr. Qasim Hussain, who are PGY3s in our internal medicine program, who are completing their ultrasound rotation with us this block at University Hospital. They will be presenting a theme on the left ventricle, both systolic and diastolic dysfunction. So without further ado, I would like to pass the mic over to Jeremy first. And please share your screen, Jeremy, whenever you're ready.
All right. Thank you. Thank you, Dr. Yu. Thanks, everybody, for joining us. And as Dr. Yu mentioned, our goal today during our ultrasound rounds is going to be sort of an encompassing picture of left ventricular function, and more importantly, I guess, dysfunction. So we'll kind of split that into two different talks, the first being on LV systolic function, and then the second being done by my colleague Qasim is going to be diastolic dysfunction. The goals of my first part of the talk with respect to LV systolic and systolic function is really going to be what's an applicable overnight approach to evaluating a patient's systolic function on a bedside ultrasound. So in keeping with that, I'm going to focus primarily on subjective analysis of the LV function. So first thing I'm going to do is start off with the case and sort of how we integrated our ultrasound assessments into the management of this patient. So essentially, this is a 73-year-old gentleman. He's got a pretty benign past medical history of dyslipidemia, CKD. He's from home alone with his guide dog because he's blind. And presented to the hospital with a 3-day history of dyspnea and productive cough. Important things to know is that he was tachypnic with a respirate in the 30s, and his CBC, as you can see there, was relatively unremarkable. So next thing is we kind of get an evaluation of what his chest X-ray looks like, and as you can see, there's maybe it's a little bit of consolidation in the right lower lobe there, as well as what looks to be a pleural effusion. So from there, I mean, clinically, you can assess that this is likely a pneumonia, community-acquired pneumonia, and the natural course would be to antibiotics as he improves clinically, look towards discharge and outpatient follow-up. But being that we're a high-volume POCUS center and we have a lot of POCUS handy staff, the staff who was on did an ultrasound, and myself and the rest of the POCUS team also helped in doing these ultrasounds. And what we found actually ended up changing our management pretty significantly. So just kind of a very brief overview, cardiac POCUS. Really the 5 basic views that you're going to get in order to assess for each of these specific functions and dysfunctions is the peristernal long, the peristernal short axis, apical fours, subcostal, and IBC. Now, in terms of the utility of cardiac POCUS at bedside, especially when it comes to LV systolic function and dysfunction, thought I had more here. I mean, ultimately, you can use this as a data point, as well as integrating your findings that you get into the patient's entire clinical picture, and it can allow you to dramatically change your management as well as assess response to that management. So when I'm talking about the subjective assessment of the LV function, the systolic function, really what we're trying to do is get an appreciation of the LV ejection fraction as well as any significant wall motion abnormalities. When you think about the LV ejection fraction and you're trying to evaluate it subjectively, really you want to put it into bins because you're not going to be able to come up with a specific number. But basically, you can tell based on your clinical assessment and assessment of the 3 findings that we'll be looking for, whether they fit into each of those bins. So the ones we think about are the normal, EF, depressed, moderately depressed, and severely depressed. And the three markers that we're going to be looking at that are helpful kind of overnight bedside in assessing for LV systolic dysfunction is the LV cavity size change, E-point septal separation, or EPSS, as well as LV wall thickening. So the first one being the LV cavity size change, and what we're doing there is on multiple different views. We get a dynamic visual assessment of the change in the LV size during systole. And really what you want to see is about a 50% collapse. Again, this is just subjective, but in your mind's eye, you want to see about a 50% reduction in the size of that cavity. And here you can also assess for regional wall motion abnormalities, as well as with the LV thickening. Pitfall here being that what we're getting is a 2D assessment of a 3D structure. So in order to really get a good view of the LV and make a quality assessment, which you need to get it from multiple different views, and we'll sort of touch on that near the wall thickening segment. So I want to give you a good example of what a patient with a relatively normal LVEF might look like in terms of LV cavity size collapse. And this patient obviously has tremendous views, which makes it a lot easier for you to appreciate that the LV cavity is shrinking and expanding as we see he's going through his cardiac cycle. And compare that to the gentleman that we'll be talking about. And if you look at the LV cavity size here, it's really not moving too much, and we're not seeing that decrease in the LV cavity size to that 50% that we would hope to see. The next marker that I'll touch on is the EPSS, the E-point septal separation. And really, that's the motion of the anterior mitral valve leaflet during diastole. And what you want to see is that anterior mitral valve leaflet get close to the RV septum. And you can put numbers on it, right? You can say, oh, it's correlates with poor ejection fraction if the anterior mitral valve leaflet doesn't make it 7 millimeters within the septum. However, ultimately, you can really assess these based on a visual approach. But like with everything, there's pitfalls, which is why you want to include as many data points as possible into your assessment to make a call. And pitfalls of this include mitral valve pathology. So you can imagine if you have mitral annular calcification or tethering of the valve leaflets, you might not see the anterior mitral valve leaflet be able to make it to the septum. Moreover, if there's aortic pathology or aortic regurgitation in particular, you can sort of imagine that blood blowing back during diastole, kind of propping the anterior mitral valve leaflet away from the septum, at which point you can get a falsely positive EPSS. So here's an example of a very good EPSS where you can see the anterior mitral valve leaflet here. There you go. Making it all the way to the LV septum. And I mean, as we talked about earlier, you can also see relatively good LV cavity size change. And then for our gentleman, as you can see here, the anterior mitral valve leaflet during diastole is barely making it apart from the posterior mitral valve leaflet, let alone all the way to the septum. Now, we did assess, and he does not have aortic regurgitation. I don't think I included the color slide of that, unfortunately. So the third marker that we'll look at, being LV wall thickening, is the thickening of the myocardium during systole. And you should see essentially about a 50% increase in the thickness of the wall. Get an appreciation for a normal wall thickening and appropriate LV systolic function. And then you measure from end systole to end diastole, and you can use calipers to get a number on this. But at the bedside, oftentimes it's more, again, a visual assessment, which at this point is also helpful in assessing regional wall motion abnormality. And as with cavity size change, we're getting a 2D assessment, 3D structure, so you want to get multiple different views. And it's important to get these multiple different views because you can make assessments of different wall segments, and by proxy, the vascular supply of these assessments. So here's a helpful diagram regarding which views give you a view of which walls. As you can see in the long axis, really you can only get the anterior septal wall, which is the most proximal to the probe, and the infralateral being distal to the probe. The short axis, you can get a more comprehensive view, but it's important in the short axis to get multiple different cuts of the LV at different lengths throughout it to be able to make those assessments more accurately. So typically, the goal is to get 4 shots of the short axis, one being at the level of the aortic valve, one being at the level of the mitral valve, one being at the level of the pap muscles or the mid-ventricular shot, and then finally the apex. And another caveat to consider when you're assessing for these changes in the short axis is that you need to include the trabeculae as well as the papillary muscles within the LV cavity. So you don't draw or imagine the LV cavity walls, including those structures. Those structures are within the cavity itself. And then again, this helps us get an idea of what blood supply is being provided to these areas, and can help us make any determinations that we need to regarding the patient's coronaries. So I'll go through a few normal echoes or focuses that look at these features. So on the left here is a view of the aortic valve, and this can help us assess for aortic pathology, as well as there's some comments that can be made about the RV and RV inflow tract on this view. On the right side, this is at the level of the mitral valve. As you can see, there's good wall thickening, particularly here on the lateral walls. And again, this patient has pretty excellent windows. So the next is a bit farther down, about the level of the mid-ventricular level, and finally at the apex. As you can see here, you can comment both on LV wall thickening, where you are seeing that good thickening and relaxation of the LV wall during systole and diastole, and no real obvious areas of regional wall motion abnormalities. And the next view is our apical four chambers, and this one on the left is important because it kind of gives you an idea that it sometimes, based on the patient's sonographic windows, it can become more difficult to make assessments regarding LV size change as well as thickening, depending on how visible that the endocardial strip is. And on the right, you can see a patient who has a far more visible endocardial strip, and you can see good LV cavity size changes, as well as thickening and thinning of the LV walls. Now, looking more towards our case, as you can see at the level of the aortic valve, there's not too much to be commented on, but as you move down to what looks to be the mid-ventricular level, there's not as great of cavity size change, but the thickening and thinning of the walls does look relatively preserved. Moving down a bit farther, or I guess on top towards the level of the mitral valve, again, the LV cavity size change is not reducing that 50% and relaxing, which makes us think a little bit more about LV systolic dysfunction. On the apical four chambers is where it's probably the most dramatic, and there's a four chamber on the left and the five chamber on the right, where you can see that LV cavity is really not getting that good shrinking and relaxation, as well as I guess the the wall thickening actually is relatively preserved in this gentleman. Ultimately, what does this mean for us and the patient? Is that based on the assessments that we did, it does seem like maybe there is a multifactorial etiology of the patient's dyspnea, which is different than the clinical presentation initially, and will actually allow us to change his management pretty dramatically. So not only treating what is his presumed community-acquired pneumonia, but this allows us to make an early diagnosis, or at least make an early consideration for a patient who has a high risk for developing heart failure, given the fact that the exposure to the healthcare system may have come initially with significant heart failure. So with this, we're actually able to initiate him on some goal-directed medical therapy, ensure that he has appropriate follow-up, as well as further diagnostic imaging to help us characterize the function of his LV. So ultimately, LV systolic function is a very useful tool that can be done at bedside for these patients to both get an extra data point, as well as assess whether or not there's multifactorial etiologies to underlying presentations that these patients are having. So with that, I'll thank you guys for listening, and I'll toss it over to Qasim to chat a bit more about LV diastolic dysfunction.
All right, guys, just a quick mic test. Can everybody hear me okay?
Sounds great. Thank you.
Sir.
Fantastic. So I'll share my screen now and go ahead and get started here. All right. So thanks, Jeremy, for doing that part of the presentation. The systolic aspect is very important now that we have like kind of a prerequisite set in place. I'll go ahead and start diving into some diastology here from a point of care ultrasound perspective. Just to note at the beginning of the presentation, this is diastology in the context of heart failure with preserved ejection fraction. There's a slightly different algorithm and different diagnostics for reduced EF. But moving on, diastology. So it's the science of quantifying how well the LV relaxes and complies. So it's cut into kind of two phases, your diastolic cycle. So it's the pull phase, which is dependent on your left ventricular myocardium's ability to relax, or your myocardial relaxation, as well as your left atrial pressure or pressure gradient, kind of pulling that blood from the left atrium into the left ventricle. And then it also has a second phase, which is can be kind of conceptualized as a push phase, where your atria kind of contract and kind of you get that atrial kick to get the rest of the blood into the left ventricle, which is also dependent on the left ventricle myocardial compliance, or the left ventricle's ability to accept blood. And that's what a lot of this kind of boils down to, and what we'll kind of go ahead and dissect throughout this presentation. So from a point of care perspective, what can we do with the ultrasound? So there's a couple of different measures we can do just at the bedside with the ultrasound, and split into quantitative and qualitative. So the three quantitative measures that we'll do in a POCUS diastology assessment include how fast is the blood moving from the left atrium to the left ventricle? How vigorously is the left ventricle's myocardium relaxing? Is it relaxing like quite aggressively, like in a young athlete, where it's creating nice big suction force and sucking a lot of that blood in from the left atrium, creating a great diastolic assessment? And then what is the tricuspid regurgitant velocity, which we use multiple views to kind of attain. And we use that actually as a proxy for our pulmonary arterial systolic pressure, which should kind of be a representation of our left atrial pressure as well, unless you have precapillary pulmonary arterial hypertension. But that's obviously like a little bit of a niche subject. And then qualitatively at the bedside, we can assess the left atrium size and volume. And this can also be done quantitatively, but that kind of is outside of the scope of a point of care assessment, versus that kind of enters the domain of a more of a comprehensive echo. And because it just becomes a bit more complicated, and you can actually find these left atrium volume index on the comprehensive echo reports if you are curious. Yeah, so first and foremost, we'll go ahead and start your diastolic assessment with the mitral inflow assessment. So how you attain this is you get an apical forward chamber and you use your pulse wave Doppler. So that's the Doppler with the two horizontal bars, and it's actually measuring flow through that spot, like in between those two bars, versus a continuous wave, which is the diamond on the machines, which would be assessing flow all the way through that entire line. So you get your apical 4 and you want to put this gate right just past the mitral valve when it's fully open. And at that point, you're assessing the velocities during diastole of the blood coming right through that valve. And you guys can see in this first part of the diagram here, this actually is what a normal waveform would look like right at the mitral valve there. So it's split into two waves, E and an A wave. So your E, as mentioned, is your early diastolic filling time. And so that's your early diastole, which is a combination of your LV relaxation and your left atrial pressure. So your left ventricle myocardium is relaxing, creating a suction force, pulling blood in from the left atrium, as well as your left atrial pressure is also creating a gradient between your left atrium and left ventricle, and blood's moving via that way as well. And typically this is larger than the A wave, which you then get in the later part of diastole with a transient period of what's called diastasis, where there's no blood movement at all. Then this A wave is a product of like the sinus node going off, shooting some electricity through the atrium, and then it contracts and gives you that little atrial kick that shoots the rest of the blood into the left ventricle. And that's also dependent on your left ventricle's ability to comply, or its ability to accept that blood. So as you move along through diastolic dysfunction, or as it worsens, you usually begin with some impaired relaxation and decreased left ventricular compliance. So basically your left ventricle is not relaxing as well, or it's not creating that suction force as much. So it's your E wave is now almost exclusively dependent on your left atrial pressure. And so your E wave kind of drops because now you're losing the relaxation aspect of things. So that's when your A wave is kind of carrying the load here of loading your left ventricle during diastole with its atrial kick, so its atrial contraction. And actually, so this part right here, historically, prior to 2016, was actually considered the first sign or first grade of diastolic dysfunction. So patients would be given diastolic dysfunction just based on this alone. However, in 2016, they actually reviewed a huge subset of patients with exclusively in this group, and they actually followed them and then saw that there was actually unclear clinical sequelae from this group. They found that this could actually just be a part of normal aging. As you age, your left ventricle kind of just stiffens a little bit, and this doesn't necessarily mean you have like heart failure or preserved ejection fraction. And there wasn't any necessarily clinical consequence from it. So in those guidelines, they actually changed it to they created new criteria for diastolic dysfunction, which we'll get into later on, but they no longer considered this to be representative of true heart failure with preserved ejection fraction. But say it was true diastolic dysfunction and it continues to worsen, as over time your left atrial pressure will increase chronically because of the drop in your because of the increase in your left ventricular and diastolic pressure kind of backs up into your left atria, and then over time it will increase. And eventually that increase in left atrial pressure will compensate completely for the myocardium's inability to relax. So you'll actually recreate this left atrial pressure the gradient here will be so large, it'll actually make your E wave look normal again. And this is actually called pseudo normalization, because your myocardium's ability to relax is still impaired, but just because of the chronic compensation, your left atrial pressure has gone so high, it's now just pushing all that blood through, and you're still attaining the same velocities you would in a normal heart. And then if it continues to worsen, then you're going to reach a point where your left atrial pressure is so high and it's creating such a strong gradient or such a big gradient between the left atrium and the left ventricle that your E velocities are now very high. And now they become so high that the second phase of your diastole, so your atrial kick, is basically doing nothing because there's no more room left in the ventricle for blood to enter during that phase. So that's where you use these EA ratios. So if it's greater than 2, then you're kind of in a severe range of diastolic dysfunction. So this is kind of a bit more of the complicated physiology to kind of understand, but this is the progression of diastology or diastolic dysfunction over time. And then a bit more intuitive is actually measuring the muscle movement of the left ventricle away from the probe. So this is, you do use a tissue Doppler gate, which I'll show a little bit later, but you place that over the level of the mitral valve, encompassing both the annulus, both the lateral and the septal aspects of the annulus. And then you place your pulse wave Doppler right over the top of the annulus, either on the lateral or the septal side, and you have to do both measurements. So this is actually measuring the movement of the myocardium itself. So as you can imagine, so you see it as a negative wave on your Doppler signal because it's during diastole, it's moving away from the probe. So as you can imagine, in a young, healthy person, a nice, vigorous muscle movement, great relaxation. So it has a nice, large E prime wave, we call it. But as your muscle's ability to relax becomes impaired or it becomes more stiff, the velocity that it moves is going to go down. So this is actually carries a linear relationship with diastolic dysfunction. So now as the diastolic dysfunction worsens, your ability to relax just goes down and down and down over time. And then these are just the normal values. Your septal E prime should be greater than 7 centimeters per second. Your lateral E prime should be greater than 10 centimeters per second. And then we use these numbers to actually estimate our left atrial pressure, which is really what we're interested in, right? So going back and taking a look at the velocity of the blood moving through the mitral valve itself, we can't use that number alone to estimate our left atrial pressure because, as I mentioned, it's a product of both the left ventricle's myocardium ability to relax, as well as the left atrial pressure kind of pushing that blood through. But now we've also quantified our left ventricle's myocardium ability to relax. So now we can kind of just put that in the denominator, divide both out, and then you add 4, which is a constant, which is determined by like some mathematicians that are way smarter than myself, and actually they've determined the Nagu formula, but then this is just derived from that, and it ends up being kind of a constant in that area. But if you take your E velocity and you divide out your E prime, and then you just add 4, you actually end up with a good surrogate for your left atrial pressure, your pulmonary capillary wedge pressure. And if you guys remember from the Berlin criteria, your non-cardiogenic pulmonary edema, the pulmonary capillary wedge pressure should be less than 18 in those scenarios with a Swan-Ganz to kind of qualify it as non-cardiogenic. So therefore, an elevated left atrial pressure would correlate with an E over E prime ratio of greater than 14. But then if you actually look up what the normal pulmonary capillary wedge pressure should be, it's between about 4 to 12. And that actually correlates what a normal left atrial pressure or normal E over E prime should be as well, which is less than 8. Which then leaves this area between 8 and 14, which is kind of a gray area. But over time, obviously, the closer you are to 8, you're going to be closer to normal. The closer you are to 14, you're going to be closer to abnormal. But that's where like you end up using other measures in all of this as well to help you kind of obtain kind of a clinical picture and make your clinical decisions that way. We never just use one measurement or one kind of golden ticket in practice anyways, right? So with that being said, you move on to measuring your tricuspid regurgitation velocity. So this is now the third quantitative measure we're doing, and this is the one that's probably fraught with the most error, just because it's difficult to get these views, and it's also very difficult to line up your continuous wave Doppler, so the one with the diamond and not the pulse wave, just completely parallel with your tricuspid regurgitant jet. And you can do this in multiple views. You could use the apical 4, you could use the peristernal short axis at the level of the aortic valve, and where the tricuspid valve just comes up on the left side of the screen. And then you could also use the RV inflow view to obtain this. But almost always, or most of the time, you're likely going to be underestimating it just because it's so difficult to line it up perfectly. That's why this is probably less commonly used in some scenarios, but certainly part of the criteria. And a normal value for this is a max velocity of 2.8 meters per second. It should be less than that. Great. And then last but not least, our qualitative measure on our point of care ultrasound would be looking at the left atria. Does it look dilated relative to the other chambers in the heart? And then you could even look for some intra-atrial septal bowing as a proxy for kind of increased pressure in the left atrium relative to the right. But this is a bit more qualitative measure, and can certainly be done a lot easier. And then, as mentioned earlier, there's the left atrial volume index, which shows up on more comprehensive echoes, but a bit outside of the scope of a point of care assessment. So now this brings us to the diastolic dysfunction diagnostic criteria per the American Society of Echocardiography guidelines in 2016. So in patients with normal LVEF, you obtain all the measurements I mentioned previous, and there's about like 12 to 15 measurements that you can actually take to help you elucidate this, but they boiled it down to these 4 to just optimize the sensitivity and specificity. And they found that an average of E over E prime greater than 14, as well as the septal E prime velocity less than 7 and lateral E prime velocity less than 10 with the TR velocity greater than 2.8 and the left atrial volume index greater than 34 are all consistent with diastolic dysfunction. But you need at least 3 of those to actually come up with the diagnosis or confirm your diagnosis. And if you actually look at these 4 variables, 3 out of 4 of them are proxies for left atrial pressure measurement. So the average of the E over E prime, and it's average between the septal and the lateral, because you calculate both and just average them out. And then your tricuspid regurgitation velocity and your left atrial volume index are all proxies of your left atrial pressure. The only thing that's not is the septal and the lateral E prime measurements, which are actually just direct measures of your myocardium's ability to relax. So there is a high emphasis on left atrial pressure throughout the diastolic dysfunction criteria here. And now this takes us to our case. So synthesizing all this together, there was a patient that came in recently, which this was perfect for. So this was a 60-year-old lady that had increasing dyspnea for 2 to 3 days. She actually had a background history of interstitial lung disease, secondary to her connective tissue disease, currently being followed by rheumatology. Also epileptic with maintaining on some anti-epileptic drugs, type 2 diabetic, history of cholecystectomy and osteoarthritis, but very pretty vague history, just 2 to 3 days history of dyspnea and a cough. No chest pain, no leg erythema, no tenderness in her legs, and really no other strong infectious fevers at home, but she did come in with a fever at 38.1. But other than that, doing pretty well, other than satting 4 liters nasal prong. But it should be noted that her baseline is room air oxygen. So as usual, she got her chest x-ray. Hazy ground glass appearance. It's hard to tell if there's any kind of focal consolidation or not, but it doesn't look like it. She got a CT scan to rule out a pulmonary embolism, which was also negative for PE. And again, you can see some ground glass haziness throughout the chest, but very non-specific findings, right? This could be an ILD exacerbation, this could be pulmonary edema, this could be an acute infectious process, but relatively non-specific. So this really doesn't help you pin down any diagnosis. So that's where we got involved. So we went ahead and performed a lung ultrasound on her to start. And as expected, I'll give it this a second to let it load, but spoiler alert, she's gonna have B-lines essentially everywhere. And there's no clear effusions on the costal views at the bottom. But diffuse B-lines, but it's hard to tell. Again, B-lines are also non-specific because they're just showing essentially pathology or some sort of irregularity in the pleural interface. And if you actually take a closer look at the pleura, it might be a little bit thickened here, and over here, maybe a little bit jagged, maybe a subpleural consolidation coming in. But the thing is, in our interstitial lung disease patients, who knows whether this is acute or chronic, unless there's some sort of significant change from previous, and they have previous scans or previous x-rays. So it's very non-specific. This could still be pulmonary edema. This could still be a viral pneumonia. This could be our differential is still pretty broad, or it could just be a byproduct or an ILD flare as well. So that's when we went ahead and scanned the heart. So we got our 4 basic views that Jeremy mentioned earlier, other than the apical 5, but we got the other 4. I'm hoping these images are loading well, and you guys are able to appreciate that here in the parasternal long, that the left ventricle seems to be contracting well. The mitral valves slapping the septum and diastole. Everything seems to be moving well in all 4 pictures. But taking a closer look at the parasternal long, you can see that maybe the left atrium might be a little bit dilated, and maybe the right ventricle might be a little bit bigger. Hard to tell. It's hypothesis generating for sure. So we move on and we take a look at the parasternal short. And I'm really hoping this is loading, because it's going to be hard to appreciate if it's not smooth. Because and I can't really slow it down here, but if you take my word for it, there seems to be a little bit of a septal bounce and septal flattening during diastole. So that's suggestive of right-sided volume overload. But again, it's very hard to tell. You can't really clinch that diagnosis just looking at one view. But then coming down to the apical 4, again, left ventricle is contracting quite nicely. Hard to appreciate the right side completely in this view, but you can see the left atria in this view, and it looks a little bit large, consistent with the hypothesis we generated in our parasternal long. So now that it's seen in 2 separate views, it's a bit more you feel a bit more confident about it for sure. And then lastly, in the subcostal view, that's where you can actually really appreciate that the right ventricle is getting to closer to the size of the left ventricle, and it's definitely not less than 2/3. So some are right-sided dilation with some left atrial dilation as well on these views. But of note, the systolic function looks pretty good on all of these views. So there's no role, at this point, maybe a month or last year for sure, I may have considered giving this patient fluids. They came in febrile. They have underlying ILD. Sure, their hemodynamics weren't compromised in any way, but for given that she was kind of screaming or could have been screaming a septic picture. I'm like, oh, maybe like 500 cc's to a liter of fluids, this patient would have been able to tolerate quite nicely, or that may have been how I treated her a while back. But now with diastology in my tool belt, we furthered our assessment and to truly see if she would respond or would be able to tolerate these fluids. So now the first step of the diastolic assessment, we took our pulse wave Doppler and got our mitral valve inflow view. And then these are what the waves look like in real life. So we have our nice E wave, E velocity coming up, that nice big spike. And then we have our A wave right after. You can note that in this one, in this specific case, the E and the A are fused. There should be a small period of diastasis. However, in this case, for some reason they're fused. It could be tachycardia related. There's other things that can kind of confound that, but the numbers are still usable. So her velocity is 82 centimeters per second, her A velocity was 55, and her A ratio is 1.5, which is within normal range between 0.8 and 2. But you can't really make too many clinical decisions just with this number alone. You can't make any jumps, just because this is both a reflection of the left ventricle's ability to relax as well as the left atrial pressure. So that's where measuring the myocardial's ability to relax comes in. So we this horizontal, this rectangular box is what's the tissue Doppler gate. It's on all the screens. So we kind of put it over top the mitral valve level, encompassing both sides of the annulus. And then you take your pulse wave Doppler, you kind of get them like hash marks right to the lateral aspect of the valve, right over top of the annulus, and you measure the velocity of the annulus going up and down. So you can see that there's a nice systolic wave right there. And then the first negative deflection is going to be your E prime. And we took that measurement and ended up at 7.8 centimeters per second, and then giving us a lateral E prime ratio of 10.5 in this case. And we did the same thing with the septal side, again, in the apical 4 chamber, not the apical 5. I know it's a little bit hard to appreciate with the still, but take my word for it, especially given that these waveforms look quite nice. Septal E prime ended up being 5.4, and with a septal E prime ratio of 15.2. And if you guys can recall, the normal values of our E prime for our lateral side was going to be 10, so it's impaired in that sense. And then our septal side was going to be 7, so also impaired on that side. And then last but not least, but we did take a peek at our tricuspid valve as well. And this I was able to get in the right, the RV inflow view. Sorry, it should be looping, but yeah, so that's, it was in my right ventricular inflow view. I put the continuous wave Doppler through it and got these nice waveforms here showing a tricuspid regurgitant velocity maximum of 3.48. And if you guys recall, the cutoff for that was 2.8. So we have these couple of these measures that are kind of telling us, oh, wait, she might be in a little bit of dysfunction here. So then next thing we did was take a look. And as I mentioned throughout looking at those scans, the atrium did look large qualitatively, like it's almost reaching the same kind of size as the left ventricle, which is significant, which is definitely abnormal. We didn't do the left atrial volume index, as mentioned, outside of the scope of a point of care study. And then taking all of this together, so these are the left side are the criteria right under the guidelines, and the right side are the numbers that we had. So looking at that, the average E over E prime 13, so still within normal limits, but the septal and lateral E primes were both pathological. Our tricuspid regurgitant velocity was also elevated. And of course, we didn't do the full diagnostic workup, but our LA looked pretty large too. So now we've met, and now we have 3 out of 4 of these that are now abnormal or within like pathological range. But then the E over E prime, I put question marks next to it because it's in that weird 8 to 14 area. And if you guys recall, that's kind of like the gray area or the indeterminate area. But it's closer to the kind of the higher end of things, right? So what would we do with this information given her whole clinical picture? So we've diagnosed left ventricular diastolic dysfunction, meeting the criteria with 3 out of 4 of these variables all being positive. Elevated left atrial pressures. So therefore we opted to diurese this patient. And then this patient, I believe, was her home dose of Lasix was 80 milligrams PO BID. And we then started 80 IV BID. And 24 hours later, I did a focused diastolic reassessment just to see what the effect of diuresis would be in this patient. And this is, again, is our mitral valve inflow view. And then now we're taking our waveforms there. So now we see our E velocity has already come down from 82 centimeters per second all the way down to 68, which is a phenomenal indicator of good diuresis. But of course, we can't really just use your E velocity for left atrial pressure. So of course, we measured our lateral and septal E primes. So the lateral E prime actually came up to 8.3 from 7.8, and the ratio also improved. And septal E prime also improved to 7.17 with that ratio also improving. Now, I should note that typically you would expect that the myocardium kind of would be moving the same throughout, like whether they're overloaded or not. But in reality, I think we do see that our E prime numbers also improve. And this could just be a reflection of you're just getting to a better part on the Frank-Starling curve. And then I also repeated TRV max, and that also came down from 3.48 all the way to 2.95. And this is all just after 80 of IV Lasix. And I believe she had received 3 doses by the time I'd reassessed her here. And I forwent the left atrial assessment. That looked a little bit similar, but I don't think you'll see anything as dramatic on that right away. So yeah. So now we're looking at what's happened over the last 24 hours. So her E and E prime went from 13 to 9, which is great. So now she's still in the gray area between 8 and 14, but much closer to the normal side than the pathological side. Her septal E primes essentially normalized, and her lateral E primes improved as well. And her TRV max has come down quite significantly as well. She's still pathological in those aspects of things. So that being said, we're now continuing diuresis, and the case is actually currently ongoing, and she's currently on the ward here at University Hospital continuing diuresis, but improving clinically and now hemodynamically improving as well. So this is a great representation of like how you can use diastology just at the point of care. And I should mention the reassessments are quite short. Like they're a lot faster. Like I didn't go through all the views. I kind of just looked for the information I was looking for. So basically just kind of getting the hemodynamics of it. And you could certainly spend more time looking at, okay, you could look for the left atrial to kind of maybe get smaller, your right ventricle to maybe get a little bit smaller. But when you're just following these patients with serial assessments, it's great to just focus on what you're looking for, get those numbers, and then see if you're moving in the right direction or whether you need to increase diuresis, change your strategy, or what else you need to do clinically. So that's where the point of care becomes really useful, because you can't get echoes this often or this frequent, right? So now you can just follow your patients hemodynamically, and like you don't have to kind of struggle to look for the JVP or other kind of physical exam maneuvers, which I mean, you could certainly still do, because at the end of the day, this is just another data point in your entire clinical picture. So I thought this was a phenomenal example. Like I'm going to rescan her, and then we'll see how she does over the next couple of days. So when else to use diastology? POCUS. So again, as mentioned throughout the talks, it can help you determine cardiogenic versus non-cardiogenic pulmonary edema etiology. Then that's like ARDS in the ICU. And it, like, I think it's largely helps with diuresis and fluid management. I'll let Dr. Yu and Dr. Sen weigh in on that to see if they have any other uses. But these are like things that we almost do everywhere our patients, like day in, day out. Fluids are diuretics, fluids are diuretics, fluids are diuretics. So I think this is very, very helpful in managing our use of fluids throughout the medicine wards here. But there are some pitfalls to kind of take into consideration when using these assessments. So first and foremost, I just want to talk about the technical difficulty of these assessments. They are tough. You need a degree of ambidextrous ability, just because you have to have one hand on the probe, kind of holding it still, kind of manipulating the machine, trying to get all these measurements, and then just be cognizant of your level of training with any kind of intervention that you're doing. So point of care ultrasound included. Like you never want to use this just as an exclusive like magic bullet to kind of solve everything for you. It's just another data point in the entire clinical picture, right? Especially there can be false negatives, false positives, and like in these measurements as well. And specifically in these ones in diastology, you have to be concerned about like non-sinus rhythm, like atrial fibrillation and PVCs, because that can alter your E wave or E velocities, just because if you're going into atrial fib, you're going to have like very inconsistent volume in your atria. So your velocities going through the mitral valve will also be different. At that point, you just have to do more averages, but that just becomes another confounder in diastology. And similarly, left bundle branch or pace rhythms, they can also confound things. With the septal movement, it can confound like the way you're measuring your E velocity or E prime velocities on your septal mitral valve annulus. And other things that can affect the mitral valve also affect this. So significant mitral regurgitation or any mitral stenosis, as well as previous mitral valve surgeries can affect your mitral valve annulus ability to move. So your E prime numbers will all be confounded by these things. And of course, mitral annular calcification, because again, it's calcified, so it's like not moving as much. So even if your function is normal, your E primes might be low. And then wall motion abnormalities. So if the basal aspect of the walls or like the septum or the lateral wall, they're not moving as well, your E primes are going to be confounded in those as well. And pericardial disease, because that affects your left ventricular myocardium's ability to relax and comply as well. And then cardiomyopathy. So as mentioned at the beginning of the talk, heart failure with the reduced ejection fraction all of it has diastolic dysfunction. It's just a different algorithm to kind of assess the grade and figure those aspects out, which are all out of the scope of this talk. So thank you guys for listening. Hopefully I was able to make diastology make sense to a degree. It's a little bit of a more complicated topic for point of care ultrasound, but yeah, took a crack at it. Special thanks to Dr. Yu and Dr. San for this rotation. It's fantastic. Me and Jeremy both had a great time. And thanks to the UH Medicine consultants and seniors for giving us patients to help develop our skills. I'm happy to take any questions. I'm sure Jeremy is as well. And then we have Dr. Yu and Dr. San here if they want to add anything to the talk as well.
Well, I'll just say, first of all, thank you, Jeremy and Qasim. This is a really wonderful presentation. And I think you guys had gone through a very nice process of talking about, the basic things that we started with, looking at LV basic systolic function, and then moving on to certainly much more advanced hemodynamic assessments, talking about diastology. One of the comments I've had with you guys was that although we call this diastology, it's not really the purpose of what we're doing. We're not trying to really look for a diastolic dysfunction or trying to grade that diastolic dysfunction because, as you alluded to, this is a very complicated topic with a lot of pitfalls that might fall into it. But day to day, we're talking about fluids or diuresis, and we're thinking about fluid responsiveness versus fluid tolerance, diuretic responsiveness versus tolerance, and in my opinion, at the very least, left atrial pressure assessment is one of the key data points to help drive that decision-making on a day-to-day basis. You also commented that, yes, this is an extra data point on top of our clinical assessment, so we should always never forget our clinical assessment and our physical exam maneuvers. But one concept that I'm more cognizant of these days is that even though we could decongest somebody clinically, their JVP is down, there's no edema, they feel great, they're not on any oxygen anymore, it doesn't mean that they're at a complete point of decongestion. And so there's clinical congestion, which we can find when it's dramatic on clinical assessment, but there's also hemodynamic congestion that we could find on sonographic assessment, as you have demonstrated today. So in my practice, at the very least, when I'm decongesting somebody, yes, I look at the clinical side of things as we normally would, assessing for quote unquote volume status clinically. But I also use ultrasound as an adjunct to further push diuresis, even though clinically they might feel good, because they might just be on the precipice of being congested again if we don't diurese more. That's just my commentary on that.
Yeah, thank you both for the great presentations. And just to add on to what Dr. Yu said, I think one of the best uses for a tool like diastology or left atrial pressure assessment is a case like this, where you can follow clinically the response in the change in the E wave velocities and your ratios. This is a patient that's going to be very hard, ILD, their lungs are always going to look and sound horrible. There's a degree of RV dysfunction here. We didn't go into it because obviously there's a lot to talk about. There's a lot of things that are going to make the decision whether or not to diurese this patient or how aggressively to diurese them a bit tricky. And so it's really nice to see, within 36 hours of intravenous Lasix, we've already seen that response. And clinically, the patient was, like on 4 liters, was down to like 2 liters. And, so you're seeing a clinical response. You're seeing the sonographic response with the quantitative values. So this is one of those instances where I think it can be very useful because you mentioned all those pitfalls, which classically a lot of our patients have AFib, MAC, all these other things that can make the diastology or left atrial pressure assessment a bit tricky. But this was a beautiful case where I think it was very useful. Well, I know it was very useful because it was my patient. But yeah, so great job, both of you.
I wonder if the audience has any questions.
Hey guys, I have a quick question. Thanks, Qasim and Jeremy and Dr. Hussain. Just did we get like I was just wondering, like, has there been like studies to like sort of prospectively validate like how often you look for like diastolic dysfunction in the same visit or anything that you guys know about from like a cardiology standpoint, or it's sort of more like consensus that you guys use?
I think that's a great question, Rachel. I think I'll first say that in terms of these indices or these potential markers for left atrial pressure, on their own, Qasim already mentioned that they don't have the greatest sensitivity and specificity. So they have to come all together along with the clinical factors, obviously. So to answer your question very, very frankly, no, there hasn't been any study looking at sort of this day-to-day assessment of left atrial pressure with ultrasound and to look at clinical outcomes as a result of that. And I think that's that's a field right for study potentially.
I also had a second question. Again, thank you guys so much for letting us participate in these rounds virtually. They're fantastic and well done today on the presentation, guys. My question was whether or not we know of a correlation between what we have on lung findings and the diastology. Like if we see the EE ratios improving, do we also see less B lines, or are the B lines just quite a bit more non-specific in terms of being a marker to track once we know that the person has diastolic dysfunction and that the B lines aren't just related to other interstitial lung disease, etc.?
I think that's also an amazing question. This was because somewhat different topic, just talking about lung ultrasound itself and B lines and the setting up ILD versus CHF versus both. It has been looked at previously that counting B lines, or just sort of having that either automated count based on machine algorithms or AI or manually counting, doesn't really work in terms of the significance of B lines or what that really means prognostically or clinically. Because conceptually, it just doesn't really make sense that way, right? It's more about the distribution of B lines and how many lung zones are affected by B lines that seems to correlate better with the clinical reality. So there's certainly, I mean, there's no direct studies looking at this diastology versus what we see on lung ultrasound. But it is in our clinical experience that, yeah, as we're diuresing patients, obviously the B lines go down, the number of lung zones with B lines also decrease along with our diastolic indices.
Yeah, and to my recollection, I think it's been a little while since I've looked into it. There's a lot of like small case series and things where they've done the hemodynamic monitoring of patients, either with like wedges or patients, I think, who were going for like CPETs and other things, and they've tried to correlate, B lines with some of these invasive tools as well. But I don't think that it's specifically been done with, B lines, someone having diastology with an echo done that day and having, a pulmonary artery catheter or something. So it's a lot of it is, inference from one set of studies to another, and clinical response and use, but it's not one of those robust things where we have big RCTs or anything else to guide us.
Are there any other questions from the audience? Because if not, then thank you again, Jeremy and Qasim, for this excellent presentation. And I thank you all for joining us for ultrasounds this month. We'll see you next time. Take care.
See you, everybody.